I'm Dean Whiting from Pathology Technology Australia. Recently, we had the very good fortune of presenting a review on rapid COVID testing to a parliamentary friends group at Australia's Parliament House. This was a very well attended review, and I was joined by three very eminent speakers. We've now turned this review into a webinar. You'll notice that at the beginning I give a short tutorial on antigens and what they are. But then I'm joined by Professor Mary Louise McLaws, Professor of Epidemiology at the University of New South Wales and advisor to the World Health Organization on emergency management preparedness of epidemics. I'm also joined by Dr. Ian Norton, the founder and CEO of Respond Global. Ian also has a very strong past history with World Health Organization in emergency management, and also has advised our Australian government through leadership of AUSMAT on regional emergency responses. And thirdly, we're joined by Dr. Henning Lilkvist, a public health consultant who advises governments in many places around the world on emergency management, preparedness and monitoring of pandemics and epidemics. Together, these three eminent people probably have more combined experience, on-ground, in-field experience of epidemic management than probably any other similar group in Australia. So we're enormously proud to be able to present this webinar and to present you with the views of these eminent experts in this area. I hope you enjoy it. I'm Dean Whiting, Pathology Technology Australia.
Today I'll briefly describe what antigens are and how they can be tested for. And we'll talk a little bit about some of the limitations and some of the myths about these tests. And just to give you a little of the geopolitical context, I saw overnight actually a report that suggests that Australia is now the only OECD country that's not including rapid antigen tests in a broad way in the fight against COVID-19. So it's a somewhat disturbing situation. But before we start, we have people attending this review from many parts of Australia. So in the spirit of reconciliation, Pathology Technology Australia and everybody here acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. And we pay our respects to their elders past, present, and extend that respect to all Aboriginals and Torres Strait Islander people today. I would like to kick off just giving a very brief tutorial on these things called antigens. What are they? So on the slide here, you can see a pictorial representation of a SARS-CoV-2 virus. And the antigens are actually the proteins wrapped around the outside of the RNA core of the virus. Antigens are anything that will stimulate the body to produce antibodies, and that's how we fight the infection eventually. So the antigens you can see on the screen represented in blue here are the nuclear capsid proteins around the middle of the virus, and the spike proteins, the ones that allow it to attach to the back of the throat and to the nose. So these antigens can be detected, and when we detect these antigens, we can measure them. The antigens in the body take the antigens stimulate antibody production, and after about 7 to 10 days, those antibodies are able to attack the virus, and they're represented here in the little yellow Y-shaped implements here. These are the antibodies. They actually attack the virus and they kill it and prevent it from replicating. So the antigens and the antibodies work together. So how do we measure them? Antigens can be measured quite easily on a very simple lateral flow device. There's a picture of one here. They take about 15 minutes and you can perform them almost anywhere. These can come in a couple of different formats with machine readable tests or human readable tests. They cost about 20% of the price of the current PCRs in use. And we have about 23 of these rapid antigen tests now approved by the TGA. They're very simple to use. The well at one end, the little V-shaped well, is where the sample goes. So you take a swab in the normal way, you elute the swab into a small amount of liquid, and then you drop 3 drops of that liquid onto the device, and you wait 15 minutes, and the sample is slowly drawn up through the lateral flow and gives a positive or a negative result. Rapid antigen tests are not perfect, but no test is. Not everybody is on board and at the moment in Australia with the use of rapid antigen tests. For example, the PHLNs and the RCPA are not recommending these tests for use widespread in Australia due to the low prevalence and a couple of concerns they've got about antigen testing. However, some of the information about these tests about in the market at the moment in the community is just a little bit confusing. We sometimes hear about the false positive rate of these tests being too high. This means that the test will show a positive result when an individual is actually negative. The real world evidence actually doesn't support this proposition at all. And we know that for example, from Howard Springs, over 7 months of using these rapid antigen tests, we saw only 1 in 10,000 tests turned false positive. So really the false positives are not that big a deal. We also know that sometimes we hear these tests are not as accurate as, say, the PCR test. And that may be true in some circumstances. But the best quality tests are actually extremely good at detecting COVID in the first 7 days or when the viral load is high. And certainly the mathematical modeling and the real world evidence shows that repeat testing at least every 3 days with the rapid antigen test gives about the same accuracy as PCR. And this gives us some clues as to how we might use rapid antigen tests in Australia in the fight against especially the Delta strain. So we're privileged today, as John mentioned, to have 3 world experts, possibly with more combined experience in hands-on epidemic management than anyone else in Australia. And it's a delight to be able to introduce these speakers. First up, we will have Professor Mary Louise McLaws. And I think, Mary Louise, you need no introduction. I think your reputation absolutely precedes you. So would you like to come in and give some advice on where we are currently with your experience with the World Health Organization data and where we see rapid antigen testing helping us out there?
Good morning, everyone. Thank you very much for having me, and thank you for listening to us. We have been supporting the idea of rapid antigen testing as an augmentation to PCR testing for a very long time now. Dean, is it possible if I just share a couple of slides? The WHO, no, I'm not given approval. That's okay. No, it's all right. No big one. I just thought they might like to see some of my my analysis. Let me just try one more time.
Dane, if you could unshare.
Oh, yes, that's good. It's all good now. Okay. Are you seeing this? I can now put it into slideshow. Thank you for acknowledging the traditional owners. I'm working on Bedigal people's land. So today I'm going to focus really on Australia and why we need it in Australia. Certainly as a member of a WHO COVID facility group looking at control of COVID around the world, they not only use or accept rapid antigen testing, but they use it as diagnostics. And we're not suggesting that today. We're suggesting it as a screening, which is very different. And I'm sure that Ian will explain the difference. So why should we use rapid antigen test in Australia? Well, here shows we are really in this 3rd wave, sadly. This 3rd wave, today we have over 900 cases in the epicenter of the 3rd wave in the Greater Sydney area in New South Wales. And this 3rd wave has sadly come as all other waves since the 20th of March 2020 from breaches in quarantine hotels. We had about 877 cases just prior to the closure of our borders. So really every other case since then has been direct or indirect from breaches, which could have been easily stopped with using rapid antigen test, as Dr. Ian Norton has so wonderfully used in his handling of the Howard Springs, where there was never one breach ever. Now, why are we in this terrible state? And we're in this state because Delta gave us plenty of warning. We even closed the border to Australian Indians coming back when they had the Delta outbreak because we knew it was so infectious. However, we have failed to really appreciate this once it's on our soil. The average case develops more than 1,000 times the viral load, which of course makes it highly infectious. The incubation period is 2 days shorter, and it's highly contagious, 50 to 60% more contagious than Alpha. And the Alpha variant of concern was 50% more contagious than the Wuhan or wild strain. I took this off the New South Wales Health, and sadly, a similar graph had it looking at after 10 cases. No, you look at one case of Delta in the community is one case too many, and we should be responding rapidly. And as you can see in Fairfield, for example, that area just doubled so rapidly. And models do help, but they cannot possibly explain the importance of behavior, the importance of culture, and the togetherness of people. And Henning will, and Ian, certainly know from experience, as I do, that when you're controlling an outbreak or a pandemic, and this is my fourth one, geography, human behavior, and culture are the most important things that you really can't put into a model. And so you really have to act fast. And this is what we're now seeing. Delta in New South Wales has sadly reached nearly 14,900 cases. I haven't updated the Victorian one yet, but it travels fast because we humans love to travel. I mean, we're interconnected in Australia. So why weren't we using rapid antigen test already between border? And we could have been doing that when we had a couple of cases. This shows you how I've been looking at both New South Wales and Victoria. And sadly, even though Victoria goes in always fairly rapidly after they experience that second wave, it wasn't nearly fast enough. It was 14 cases, sounds good, but it has to be with one case, just with Delta. And so why do we need to think about rapid antigen tests in the future? Because we are not going to get back to zero. I can't see that happening. So we're going to have to open up safely, and we can with more testing and of course more vaccination. So as we can see here in New South Wales, we had yesterday a bit of a dip, but that was an artificial one. And both Victoria and New South Wales cases are heading skyward. They're not coping with the pressure, as you can imagine. No blame there. It's just the reality. This is my very easy on the back of an envelope analysis, and we will be hitting 1,000 cases. I predicted this a couple of days ago, but this is going to happen. Once we reach 1,000 cases a day, well, we're already not probably ever going to see zero. Vaccination certainly is important, but I'll just remind you that not every vaccine gives 100% coverage. And your first dose stops you from dying, stops you from probably going into hospital, but does not stop you from transmitting it until the second dose. So what, oh, sorry, there's far too much for you to read. You shouldn't have been seeing this one. This is like opening up a drawer in a closet. It's very messy. So here, what I'm trying to say is when we open up at 70 or 80% of the total population, be very mindful that that basically means of the adult population. We really need to vaccinate the kids. So regardless of what the government will or won't do, this is why you need to do rapid antigen testing, because at 70%, there'll be a proportion of adults that have never elicited a highly protective immunity, and they will be a case. All the kids, the 4.8 million, will be a case. And that 30% of adults that never had a chance to get vaccinated, they can be a case and a source. If we open at 80% of adults, again, all of the kids, plus 20% that didn't get vaccinated, plus those that failed to elicit a perfect response. So not everybody will be protected. So what does this mean? And how can rapid antigen test help? Well, as I mentioned, a large proportion, shockingly, 13.6 million to 6 million will be unprotected. There'll be a source, they could be a case, and they could be a source, but they don't look it. And you, as we know from Delta, you can spread it even without looking if you're ill. We still will have high hospitalization due to breakthrough infections in the elderly. And I'm very pleased that Ian will be able to share his experience with using rapid antigen testing in residential aged care facilities. We have had multiple breaches in our quarantine program, at least 43,000 at least, but we could have introduced rapid antigen testing to ensure that no one leaves quarantine unless they leave safely as a guest, and no staff leaves to go back into the community, including drivers, absolutely everybody. And until we get full vaccination from the front door to the back door of hospitals, every staff member, and if you've ever worked in a hospital, everyone knows everybody, and Delta won't just stay with clinicians. So not everybody also complies with public health measures. So rapid antigen testing would be very, very helpful. We'd be able to open up a business much more safely. So how do we keep deaths and hospitalizations low and health services functioning? How do we keep businesses, schools, and internal borders safe and keep them open? Well, Ian Norton and Henning will now share with you their experiences. Thank you for listening.
Thanks so much, Mary Louise. I think it's my turn now to speak and to run through, I suppose, some of the practical real-world examples and use cases. My first experience, I suppose, with rapid antigen testing as a group at Respond Global here, we were asked to look at this back in July and August last year of 2020. The reason being that we had some marine and cruise company clients in Europe who were asking us, well, we want to get back to some form of normality in the European summer of last year. Could we look at new forms of testing that seem to be coming in the market? I was very healthily skeptical, and I went off and researched exactly how it could be used. Certainly in my old work for 6 years at the WHO, managing large outbreaks around the world, we certainly use these forms of rapid detection tests, and it's an adjunct when you're fighting an outbreak. And it was very interesting to look at the practicality of screening 2,000 people before they board a vessel, for example. And this is what we put in place back in August, September last year. Howard Springs asked us to get involved at the quarantine center. It was really a staff-driven and a senior management-driven decision to say, here we are doing something for the national interest to manage this great quarantine center in Howard Springs. We'd like you to look at the science and the evidence of what other testing we can put in place, ideally daily, so that our staff feel more comfortable when they go home to family at the end of the evening into our vulnerable communities and places with Indigenous healthcare needs and other things. There's some specific risks in Darwin, as we all know. And we looked at the evidence around this and we said, right, we're going to practically implement one of these rapid antigen tests we selected from a suite of looking at the evidence available. And some really interesting things came out. We worked on ways to protocolize a single supervisor managing 15 staff at a time so they could self-test in front of that supervisor and make sure it was done correctly, but done very quickly, and move through groups of people so it's not a delay as you come to work each day. The comfort and level of comfort amongst the staff, be that cleaners and drivers, the police officers and security guards, the health workers and caterers, all of them feeling much more comfortable that they were actually going through a screening process daily that was giving them surety when they go home to loved ones. I suppose that then made us ask, well, where are the other uses? What is happening in the UK, the US, and Europe? How is this tool being used as an adjunct to, of course, we all need diagnostic testing through PCR, but as we started to see variants appear, and with the variants, and Mary-Louise always talked about extra viral load, it's actually more useful. These tests are actually more effective when you have more viral shedding. And therefore, something that gives you real-world response within 10 to 15 minutes, and you can actually action that intelligence rather than hear about a test result tomorrow or the day after. We really felt there was application. We worked with several groups in resource sector and others and put that in place during small outbreaks. But it was really in the last 6 weeks that we've started to get some much closer use case scenarios. Particularly, I'll speak to aged care. Aged care, we were involved in supporting federal government to go into Victoria during August, September last year. So we helped run the Victorian Aged Care Response Centre when 165 different aged care facilities were affected at once. And suppose our coordination of health emergency response was required, and having state and federal groups work together with the providers and the NGOs who are supporting to have a common theme and a common way of working together. What was happening at the scene was that when a new aged care facility was affected, the public health department would come in and then furlough 50 or 100 staff at once. And we didn't have any extra staff to come in. And what we were facing then was this terrible situation where older people were then not being fed or watered. We were finding some who hadn't been seen for 10 hours and would drink a litre of fluid when the team arrived because they were so dehydrated. We were finding that without that lack of staff and some way of risk controlling, we were starting to lose people. So if we were to ever have it again, I was advocating even from then, please look at rapid antigen testing as a way to screen critical staff so they can continue to come to work and we don't have to furlough large numbers just because of an isolated contact. When we took this to a group called Widdens, they very bravely stepped forward without any actual direct support. They did this privately and asked us to look at a 2-week trial, and now that's rolled out to another 15 facilities. And we have now worked with the Department of Health, and this is going to roll out across the large residential aged care facilities across Greater Sydney right now, particularly in the affected LGAs. And this is to sequentially screen all aged care staff coming on site every day with rapid antigen test. What happens is we check them for their temperature, check for any symptoms, and make sure if they have symptoms, they go off and get PCR tested. If they don't have symptoms, then we swab them, make sure that they don't look like a viral super spreader, and therefore they can come to work for the day. We do the same for contractors and the same for those visitors who have to come in for emergency or end-of-life emergency visits. We've also had some practical experience of doing this now for some of the major banks. I can tell you without breaking any confidences today, screening in Parramatta at one of the branches, we've had a positive, and we now can safely say to all those staff, now please go and get confirmatory PCR testing. We're going to shut down that branch. We're not going to have visitors coming in, and we're going to deep clean, and we're going to get on with business. We're doing the same for distribution centres, and there's lots of use cases now where somebody's been screened before arrival into that distribution centre, and we can safely take that person off and look after them and get them tested. And the distribution centre delivering critical items, food, meatworks, all sorts of other use cases can continue while we're going through this outbreak. We're seeing the same in travel and cruise and in the resource sector. I suppose my last point really before introducing Henning will be to say that it's not just about delivering test kits to a business or to an aged care facility or to a hospital. It's actually the protocols and the training. That's really where we're supporting these businesses. Need to understand the collateral that you need, about 16 different bits and pieces you have to think about if you're going to roll this out safely. It's all about flow and movement of people and not becoming an impediment or creating bottlenecks, and also communication with staff, and then training of those supervisors who have to be on site to make sure it's done properly. And if there is ever a positive, they know the protocols of what to do with that person immediately. I think the future is looking very, very bright. We're certainly learning from our colleagues across the world on how they've used this particular tool as an adjunct to existing outbreak management. But now I'd like to pass over to Henning Lilliquist, who has a huge amount of experience in public health emergency response, both in preparedness, but also in outbreak and pandemic planning and response. Over to you, Henning.
I'm now unmuted. Thanks, Ian. I will be talking about use of rapid antigen tests in a slightly different setting, in a private setting. And it will be a continuation of the story we've already heard from Mary Louise and Ian. I, like Ian, pretty much at the same time, about July last year, started to look into the use of rapid antigen testing. I was very familiar with using them from humanitarian emergencies where we've used rapid antigen tests for detecting malaria, for example, or HIV. And as soon as I became aware of them being available in Australia, I assisted to have them introduced with a television production in regional New South Wales. So that's where we started about a year ago. This was a very large production with about 450 or so people. Tests were a bit hard for us to come by. Supplies were hard to get. So we weren't able at that stage to do regular testing for all the 450 people every 2 or 3 days. But what we did was we extended the quarantine and pre-access to the production site program we already had with PCR, and we had everybody tested with rapid antigen before they entered the site. Which added extra security because, as Ian has already pointed out, with the rapid antigen testing, we eliminate that whole period between swabbing and getting the results, so we can have stronger confidence that somebody is not transmitting at that stage. In addition, on this TV production, we actually had a medical crew. So we did not only test asymptomatic people here, we also tested symptomatic people. So the moment somebody experienced and reported symptoms, whether they were in their residence or on site, they were isolated. The medical crew would come and examine them and do immediately a rapid antigen test, but at the same time, take a swab for PCR in order to meet requirements with public health authorities. So the PCR swab specimen would be sent off to a collaborating laboratory, but rather than waiting for the results, a positive rapid antigen test would then have allowed us to take immediate action with isolation and start with contact tracing activities and provide information to the public health authorities concerned. Now, during that production, we did about 2,000 or so tests, and we had no either true or false positives in those 2,000 tests. Following that, later last year in November, I think it was, Opera Australia had been in an organizational sort of live performance lockdown for quite a while, and they were looking at getting back to do their first performance when some of the restrictions had been lifted. And I had been advising them with their very solid COVID-19 safety plan. But when the rehearsals were about to start, it coincided exactly with the outbreak of the northern beaches in Sydney. And so suddenly the risk profile was very different. And by then we had slightly better access to rapid antigen tests. So we decided to implement these tests in the plan while also notifying the public health authorities for the New South Wales Ministry of Health and also the local public health units there. What we did was we had slightly different tiers. So we tested all the performers and technicians around them, but at slightly different intervals. That was cost and resource saving measures. So the people that were doing things that were most likely to produce high levels of aerosol, which is how this transmits, the singers, the wind players, for example, they were tested every 3 days. And technicians around them, makeup artists, or audio technicians and others, they were tested every 5 days. And that produced for us a better management of risk, so they were able to continue with their work more safely during that Sydney outbreak. With the local public health unit, we were able to establish direct lines of communication so that in the event of a positive, we could have an on-call number if it was after hours, and we were able to contact them straight away, and then also work with them to determine how to proceed with isolation of an individual or hand over contact tracing data, as it were. The benefits of this, now this is a continuation from what we've already heard. The individual organizations, of course, benefited because their risk was reduced. The risk of transmission within their activities was reduced. When it comes to live performance, of course, patrons also were better off with a lowered risk of picking up COVID-19 from somebody within the organization. But probably more importantly, the general public was better off because we were testing asymptomatic people. And as we already have heard, and we no doubt know from before, people without symptoms transmit COVID-19. And at that time, or mainly still, the government testing program focuses on people with symptoms. So here we were testing people without symptoms, and we were therefore expanding our ability to detect people who could transmit the virus. And therefore we were making the world safer for everybody. We were actually arguing already back then about introducing this kind of testing for, of course, in quarantine before people were released. But as Mary Louise said, and Ian mentioned too, I think if we had been testing quarantine workers or high-risk workers at that time, we probably would have had much lower probability of having virus leak into the community. So we've been advocating for introducing rapid antigen testing in these settings as well. Another benefit that we realized it was there, but we were a little bit surprised. Of course, we're testing asymptomatic people, so we need to have screens. We need to screen people for symptoms like Ian described. And we were a little bit surprised in the beginning that we had a fair few people turn up to this the screening point and report on the form that they had symptoms. Now, that was probably because they were denying even to themselves. They felt a bit fatigued, that they may have been doing a lot of singing or talking and had some voice box fatigue or a hoarse voice, and thought initially to themselves, well, it's probably nothing. But when it came to the point of doing an actual official form that required a signature and in front of somebody, they would admit to themselves and then report that yes, they did have symptoms. And so we actually found more people with symptoms and got them tested through the official government audit program than otherwise would have been the case. These people would simply have remained untested, denying their symptoms, unless they became worse, of course, and they were very clear to them. And that was initially a slightly an unforeseen benefit of this. I'd like to describe, or rather list and then answer to some very common criticisms and arguments against rapid antigen testing. The first one we've already heard mentioned, that we've heard that rapid antigen tests are actually dangerous for the public because they can produce false negatives, and that is a negative test result in somebody that actually has the virus. And well, the answer to that is that, well, yes, they are slightly more likely than the gold standard test to produce false negative. But if doing it in repeat every second or third day, we're actually bringing it up to the same level, the same likelihood as PCR. And even one test is likely to pick up somebody who's in their infectious period. But I think the most important point there is that we're testing asymptomatic people here. So if they had not been tested in this kind of program, well, they wouldn't be false negatives. They would simply be untested positives, and they would be spreading it anyway. And doing this kind of thing, we would pick up far more positives than if not doing it. So there is no possible way that doing this is in any way dangerous for public health. It only reduces the risk. The other argument is about producing false positives, and we've already heard about that. There is not a public health concern in that. There is perhaps a risk to individuals in terms of just being inconvenient while waiting for a confirmation PCR, which is negative, and maybe a slight organizational inconvenience, but it's not a public health concern. The third argument, which is very common, is that by doing this rapid antigen testing in various settings, we take people away from the PCR testing programs that the government wants people to participate in. But as we've already heard, that's not true either, because we actually encourage more PCR testing, and we encourage more people to admit to themselves they have symptoms and therefore get PCR testing. So none of these arguments really have any logic to them as far as I can see. In terms of where we could head in the future, while we still have, I don't know if this is controversial, but obviously compared to the way things look globally, we have very low case numbers in Australia still. It is still very important that we have organized, controlled, supervised, audited testing procedures according to protocol, like Ian has described. But once we get further on into the evolution of this pandemic, I think that where we should head is to free testing like this up more, like what's happening in the United Kingdom at the moment, where people can actually test themselves at home. They can simply order a test kit or a box of kits, which is delivered for free to their home, and they test themselves. In Australia, there's some resistance to that. Well, there is some logical reason for it now, because we still want supervised, organized testing procedures. But my belief is that if that were available, most people would actually do the right thing. They would test themselves before socializing, before going to work. If they found a positive test, most people would do the right thing and report that and get it managed appropriately. So I don't think there is any danger in doing that either. The only thing it could provide is more information about the pandemic and a better opportunity for people who are infectious to isolate themselves and to inform others so that they can quarantine themselves and also get tested. And I think it's an additional, very solid way for us to add strength to the response to this, and also in how to learn to live with a virus that most likely is not going away for a very long time, if at all. And that's all I had to say. Thanks. Back to Dean.
Well, thank you so much, Henning, and to Ian and to Mary Louise.